Assalamualaikum and hello guys, welcome to Connection Space. So this time we are going to cover the CPG management of breast cancer 2010. Okay, so Bismillahirrahmanirrahim. Basically we are going to cover the risk factor, screening, diagnosis, investigation, and then of course the management, which consists of the surgical, systemic, endocrine, and radiotherapy. And at the end of it, we are going to cover a bit about follow-up and lifestyle modification. Okay, so without further ado, let's continue. Where is the introduction? Okay, here. Alright, Bismillahirrahmanirrahim. I really like epidemiology. So, what is the stand for the breast cancer? Basically, it is the commonest diagnosed cancer in women. It consists of about 29.9%, and this one is taken for female 15 years onwards. But the peak age, which we must know, is within 50 to 59. So for Malaysian, it is within the postmenopausal age commonly lah. And then as for the bangsa, what is bangsa? Race, yes. It is most common within Chinese, Indian, and followed by Malay. So if you look at this table 1, the Chinese is actually highest compared to Malay and Indian in all ages, but within the 50 to 59, it is the highest. Okay, that is the most highest. Commonest age. Okay, and if you look at this graph, the peak is within 50 to 59. So I'm repeating the same thing, I'm sorry guys. Okay, what are the risk factor? We need to know risk factor kan. So the first one is gender, female. Although female is the most commonest, there are cases where male also develop. But if you take 1,000 of the breast cancer case, maybe one patient is male. But it's still there, And the age is for premenopausal 40 years and postmenopausal is 50 years. That is the risk factor. And if the patient has history of that neoplastic disease, one of the risk factors also, prior history of breast cancer, it's either you have lobular carcinoma in situ or ductal carcinoma in situ, DCIS, and you are at risk of developing invasive breast carcinoma. And even if the biopsy shows proliferative with atypical hyperplasia, that's more common. And in terms of the family history of the first degree relative, and if compared, sister is more risk than the mother. And of course, BRCA1 and BRCA2 is a very famous family history risk factor. Radiation exposure. Unfortunately, patients who had therapeutic radiation, they are also at risk. Okay, and of more, what I'm trying to say, sorry. Contralateral breast cancer, Hodgkin disease. Well, Hodgkin disease usually require a very high dose of radiotherapy, so that's why. And then, but this is the one thing that this is new for me. I didn't know that mammography actually does not show any effect on the breast cancer status, even though it's also a radiation. Okay, so that's a good thing. And regarding the reproductive factor for pregnancy more than 30 years, nulliparity, because breast cancer is about hormone, right? So if you do not have like pregnancy, so the hormone is more. So nulliparity cause breastfeeding. No, breastfeeding is protection. Yeah, and oral contraceptive. If it used longer, it can have high risk. And then unopposed estrogen use in hysterectomy, but estrogen use like if you use more than 15 years, and then combination hormone therapy, menopause, more than 55 and menarche less than 12. breast density. Unfortunately, high breast density, they have higher risk. And regarding the lifestyle pula, if patient has BMI more than 25, that is higher risk. And it is shown that small waist and waist hip ratio is actually a protection. And alcohol, if you take more than 10 grams per day in postmenopausal especially, that's a risk. And then it's shown that if we exercise, it is actually a protective, inversely related to the breast cancer. This is the risk factor stratification. Oh my god, actually the same je. But if you want to take a closer look, this is easier lah. High risk, I will take about this high risk one. Patient who have history of invasive breast cancer, LCIS, DCIS, that is high risk, atypical hyperplasia, radiation, BRCA1, first degree family history. Alright, for screening. Screening, there are a lot of debates. Whether you want to use mammography, you want to use ultrasound. So this discussion is going to conclude what is the best screening of all. Alright, so of course screening, they say, can reduce the cancer mortality, but it can also cause overdiagnosis and overtreatment if we do not use the proper screening method. And yeah, regarding the mammography, we do screening for women 40 to 49 years, okay. And then other than that, ultrasound and MRI, it actually not for screening, but to adjunct in treatment and planning for staging. Okay, ultrasound and MRI. So basically, what should we use? To community, mammography is the main screening tool. Okay. So a mammography may be used for patient at the age of 50 to 74 years, and then this is a must. For patients who are 40 to 49 years old, it's not used routinely, and especially if the risk factor is only low and intermediate. For patients with high risk group, MRI plus in addition of mammography must be used. Okay, and it should begin annually at the age of 30 years. If you remember what I said, high risk group, patient with BRCA, patient DCIS, SCIS, and who have atypical hyperplasia. Okay, and you see the recommendation screening for the high risk must use both MRI and mammography. Okay, but noted here that MRI not performed in lobular carcinoma in situ and atypical hyperplasia. So how about this referral? It is said that if we refer immediately the patient with breast cancer, it can improve the mortality survival rate. And we have this fast track detected, fast track clinic, and usually if we compare the fast track clinic and routine clinic over here, urgent referral and also routine referral. If urgent, meaning how urgent is urgent? Urgent is within 19 days, and routine is the waiting time for the patient is 154 days, which means like 5 months lah for the patient routine. So if we refer early within this day, and who do we want to refer early? There are patients who are more than 40 years old with breast lump more than 3 cm. If actually in terms of breast cancer, if more than 2 cm is dangerous lah. And then sign of malignancy, but of course it depends on a few other criteria that we look also. Okay, so how do we diagnose patient with breast cancer? This one, triple assessment. Every medical profession know what triple assessment is. It consists of clinical assessment, imaging, either you ultrasound mammography, or and also pathology, which means we take the biopsy. So here we have core biopsy and FNAC, fine needle aspiration cytology. So which one do we want to use? Okay, so yeah, here I say use triple assessment to diagnose it. And because here triple assessment, you can get this almost 100% sensitivity and specificity. Okay, if we want to see the accuracy of diagnostic for the ultrasound, uh, if we add if we at first we do mammography, and at first we do mammography, we found out it is negative, and then later we complement with ultrasound, we can actually able to detect 20% of the cancer that actually found negative. So that is a good thing. What it's trying to say actually, for patient with breast symptom, we need to do the triple assessment, and then if we adjunct ultrasound, it can improve breast cancer detection in all symptomatic. Okay, and if patient who are younger, because if you remember, in mammography we start at which age kan? For patient who less than 35 years old, we only do ultrasound, okay, as the initial imaging modality. And then regarding the preoperative MRI, whether do we need to do or not, kan, in preoperative patient? It may be considered, okay, because it poses benefit, and but how do I say consider? It only consider in case if the MRI result will change the surgical management. Okay, if you think so, that's when we do the MRI. Okay, this one is said here. For example, if we don't do MRI, we may do surgery. We may take out the tumor about 5 gram. But if we do MRI, we found out that the tumor is more extensive, and we found out that we need to take out 7 gram. So that is when MRI is indicated. Here you say MRI is considered in clinical situation where imaging modality is unreliable. So the examples are invasive lobular multicentric, patient with BRCA1, BRCA2, and there's no not growth, but there's presence of nodal. If patient have implants, recurrence issue, and then if we want to follow up neoadjuvant and patient with breast. So most of these cases, it is unreliable, then we proceed with MRI. Okay, for the recommendation, it says here, not routinely done. MRI not routinely done except for this patient. Okay, it is considered in this one is only the repetition. Okay, you know what, guys? I think I'll stop here first. Okay, because staging is another topic. So yeah, we'll see you guys very soon. Bye.